Welcome to the Infection Preventionist Series. Surveillance, what do I need to track? My name is James, and I'll be your operator for today's call. At this time, all participants are in a listen-only mode. Later, we will conduct a question-and-answer session. During the question-and-answer session, if you have a question, please press *1 on your phone, or, of course, you can ask a question through the chat feature on your screen. I'd now like to turn the call over to Diane Dohm. Ms. Dohm, you may begin.
Thank you. Good afternoon, everybody. Thank you for joining us today. My name is Diane Dohm. I'm one of the project specialists here at Metastar. Metastar is the Wisconsin portion of the Lake Superior Quality Innovation Network. Today we have the beginning of our Introduction to Infection Prevention and Control, an open call series. This is meant really for the beginner infection preventionist or for those that just want a very general overview. It's going to be kind of high level. We don't have the time to cover each of these topics in its entirety. The first call today, as I said, will be on surveillance. What do I need to track? And then these calls will occur bi-weekly. So we'll go over the second call data. What do we do with this data that we're collecting? Third one will be outbreaks, identification and management. We'll then transition into transmission precautions, making them the least restrictive that they can be for our residents. We will also cover in the fifth one common citations and what are we missing, as well as training opportunities and where can I learn more. So these calls are not meant to be a substitute for the requirement as part of Phase 3 in the final rule. The verbiage of completing specialized training in infection prevention and control, that is much more extensive than we're going to be able to do during these series. They're really just meant to introduce the basic concepts of infection prevention and control and discuss some of the common issues that we have. Our objectives for today: we're going to talk about what your surveillance plan should include, talk about your infection logs and specific infection worksheets that you'll also utilize. We're going to identify sources of data, discuss using standard case definitions, and finish up with calculating infection rates. And as our moderator said, you can put a chat or a question into the chat box at any time. We'll save those for the end, as well as then you will be able to also ask them over the phone. So surveillance. What is surveillance? The definition that comes from the Association for Professionals in Infection Control and Epidemiology, or APIC, A-P-I-C. Surveillance is really an ongoing, systematic collection, analysis, interpretation, and dissemination of data. Purpose being to identify infections and infection risks. So why do we do surveillance? It is really to reduce the morbidity and mortality from the infections that your residents might have and to improve resident health and well-being. So we're going to talk today mostly about collecting the data, and then we'll expand on our next call into the analysis, interpretation, and dissemination. Each of your facilities should have an infection prevention and control plan, which includes a surveillance plan. It's really based on your facility assessment for identifying, tracking, monitoring, and reporting of infections. It needs to be unique to your facility. Depends on your types of residents, whether you do, say, dementia care or other specialized treatments, whether your residents have indwelling devices, central lines, ventilators. And it can also depend on the structure of your facility. What's the age of the building? Is there spatial separations of buildings, etc. Data collection is important for early detection and management of a potentially infectious and symptomatic resident, and implementation of the appropriate transmission-based precautions. We're going to be using evidence-based surveillance criteria. It comes from the National Healthcare Safety Network, NHSN, long-term care division, and it really mirrors very well McGear's criteria, which many of you are used to using. So that definition of data collection comes from the critical element pathway, of infection prevention, control, and immunizations that you should all be aware of as well. So in order to know what reportable communicable diseases, your staff needs to be able to identify to whom and when those diseases, healthcare infections, and potential outbreaks must be reported. So how clear is your policy? Can they pick it up and follow it? Do you have a checklist for the weekend or the night or an agency employee? What happens when infection prevention is not in the house? How does that work? So really having that spelled out in your plan is very important. Also should include prohibiting employees with a communicable disease or an infected skin lesion from having direct contact with residents or their food. Again, this comes from the critical element pathway. So employee health surveillance is also part of what we're going to talk about today a little bit. Again, it is very easy checklist for people to follow when the infection preventative isn't in the building. If you think about your surveillance log, when we talk about that, it is really just a master line list of all the infections that you discover about your residents. You want to, on that log, keep track of various information that's listed here. You're going to identify your resident using their resident number or medical record number, something that stays constant, so not a room number, although you do want to record their location as well. That can be very helpful in outbreak situations. The date of their current admission, the date their symptoms began, if you did any culturing or testing, was there an invasive device, and if there was, what's the insertion date and removal date? If cultures were done, was there an organism identified? Was it a multi-drug resistant organism? So from your surveillance log, that's really where you're starting, and then from there you'll have a worksheet for each infection type that'll have more details. Your surveillance log will probably also have a column for whether it's a facility onset or a community onset. And we tend to use a definition that a facility onset is something that occurs greater or equal to 72 hours after admission. You'll want a column to remind you to do that infection worksheet that we talked about. Did this infection meet criteria? So if you're using the Greer's criteria, did you have to initiate transmission-based precautions? What was your start date and your end date? Was the provider notified? Were antibiotics started? What was the date started and the date discontinued? We'll talk a little bit more about antibiotic information as well. Is this part of an outbreak? Is there a requirement to report this to public health? All things that are part of this surveillance log or your master list, if you will. So part of that, and whether you're doing it on the surveillance log or whether you have a separate log for your antibiotic log, you want to be documenting what antibiotic was prescribed, if any, the dose, the route, the frequency, the start date, the end date, whether you're keeping track of it on this log or another log, your total number of days of therapy, and did it meet criteria for appropriate use? So I have a link in the slides here from our Lake Superior Quality Innovation Network website that gives a sample log that you can use for your surveillance log. On that log, you'll also want to put any additional information that was unique to that resident's infection, any special notes, etc. Your State Division of Public Health may also have a sample log that you're using. What kind of infections are you tracking on this log? We'll start with kind of the basics that probably everyone is. Urinary tract infections, whether they had a catheter present or not. Gastrointestinal illness, general illness, or norovirus identified. C. difficile infection. If you had wounds with a culture, what was the organism? Influenza-like illness, respiratory illness, pneumonia. You may also track conjunctivitis, scabies. Other infections will really be identified by the risk assessment that you're doing for your facility. If you have patients on ventilators, you're going to be monitoring ventilator-associated or VEMS and pneumonia. But again, your facility risk assessment really guides what you need to include on here. You have central lines for your residents, surgical site infections. If you have a lot of post-surgery, rehab patients, that might be an important one for you. It's very important to use standard case definitions for your infections. So what you're using, what your facility decides to use, needs to be consistent. So whether it's Nadir's criteria, Loeb's criteria, or NHSN definitions for reporting purposes, you want to be consistent in always using that same case definition so that you can do infection comparisons with your data both internally, over time in your facility, as well as externally to like facilities. And as you know, identification of an infection is not based on a single piece of evidence. Say if you're evaluating a resident for a urinary tract infection, you're not just looking at that culture report. Within that case definition, there are usually multiple criteria that that resident has to meet. How do you get your infection data? This probably differs from every facility to another. Do you have an electronic automated medical record, an EMR, that triggers certain things that perhaps come to your inbox? Do you have to go in and look at culture reports and other laboratory reports? Do you get notified of antibiotic starts? Perhaps that comes from your pharmacy. Two of the most important things to make sure you're not overlooking is symptom reporting at morning huddle. Are you able to attend that, or do you get that information? And rounding and visiting the units. All those are ways to find that data initially. How do you know who is suspected of having or does have an infection? When you want to calculate infection rates, the basic definition is really the number of infections divided by the population at risk times a constant to equal your rate of infection. And that population at risk may be expressed as simply as the total number of resident days if you're looking at something like norovirus, or specifically as, say, residents who have an indwelling urinary catheter if you're looking for catheter UTIs. So that differs by the infection that you are looking at. The constant is part of that mathematical equation. It can be expressed as a relationship to units of population. So for something like C. difficile, we express that per 10,000 resident days. For central lines, it's usually per 1,000 resident days. It really, again, is a constant that's used to mirror that definition that you're using, so it's always consistent. When you're looking at tracking both outcome and process measures, we'll talk about outcome measures first. Outcome measures are really considered to be the result of the long-term care facility's practices. So you're looking at infection rates, for example, urinary tract infection rates. You might also look at, say, specific provider rates, if that's applicable to your facility, so that you can make comparisons. Those are outcome measures. You also are going to be looking at process measures, doing auditing. So I've listed here several of them that you may be doing or might want to consider. And hygiene, compliance, what's your adherence to your policy for glove and gown use? Do you do any monitoring of the cleaning of your resident rooms, whether it's daily or terminal cleaning? How about your cleaning and disinfection of shared equipment, such as glucometers, podiatry, and dental equipment? How are your things like blood pressure cuffs, rehab and therapy equipment, how is that cleaned? Do you do inspection of things like shared bath pads or wheelchair pads for breaks? Do you monitor your point of care testing? Really, process measure surveillance looks at, are things done per your policy and per the way your staff has been trained? And if not, how do you correct that? You really don't know those answers unless you are actually monitoring and auditing. Again, some additional process measures. Monitor medication administration, injection safety practices, wound care, oral care, perinatal care, catheter care, vascular access device care. As you can see, there's a lot of process measures that you could monitor. You really want to use your facility risk assessment to prioritize those process measure surveillance, and you maybe are going to rotate some of these through once they become fairly stable in your compliance. Maybe this quarter you're going to focus on wound care, and the next quarter you're going to focus on another one. None of you have the time to do all of these at one time. We're going to talk about outbreak surveillance on a later call, but you do need to know what is your facility's definition of an outbreak. This can vary by the illness, it can vary a little bit from state to state, but really it is, for some things it's one, excuse me, there's a typo there, one case of a highly communicable infection. It can be infection trends that are a percentage higher than your historical rate that your facility would set. Another common definition, 3 or more cases of the same infection over a specific length of time on the same unit or another defined area. So know what your definitions are. And again, we'll talk more about that on a following call. You mentioned antibiotic usage being part of surveillance as well. Knowing your antibiotic usage is really one of the first steps of antimicrobial stewardship. You need to know what antibiotics are being prescribed in your facility, how many are being prescribed, are they appropriate, and is there differences between providers? All those pieces of information can really lead you to what your antibiotic stewardship committee should be focusing on. So now that you've collected that data, what does it mean and what do you do with it? And that'll be the topic of our next call in 2 weeks. We're trying to keep these calls to about 20 minutes so we can give you some time for questions. Be sure to register for our next call. And on the completion of today's call, we will have a certificate of attendance link, and that will also be posted in the chat box. Some general resources for you listed here that are just really kind of what I consider all-purpose resources. So we've got a couple of specific Wisconsin ones here. You may have similar ones in your own states. CDC links for long-term care settings, the National Nursing Home Quality Improvement Campaign, McGear's criteria. APIC puts out an infection prevention guide to long-term care, and on our Lake Superior Quality Innovation Network, we also have many resources for you as well. So the link for the evaluation will be posted in our chat box. Once you complete that and get your certificate, I always recommend that you should be saving those certificates until we really know what the requirements will be to satisfy Phase 3. With our infection prevention and control training, I think that's a good start of something you can certainly show the surveyors when they come into your buildings. So the fact that you are keeping up with any information such as today and the rest of our series of webinars that are being offered. So we can open it up now to questions. You are able to put them into the chat box, or our operator will give us directions on how you can do them over the phone. If you think of any questions after the call today or in preparation for the calls upcoming, any of the topics, you can send them to my email address there, ddohm@metastar.com. It's really helpful to have those questions ahead of time. I can see that they placed a link to the evaluation in the chat box now, so that's there for you as well. And all of our questions and answers will be compiled into a FAQ or Q&A document, and that will be posted on our website after the completion of this series. So if the operator would remind folks how they can call in with a question.
Certainly. If you have a question, press *1 on your phone. If you wish to be removed from the question queue, press the pound sign or the hash key. There may be a delay before the question is announced. If you're using a speakerphone, you may need to pick up the handset first before pressing the numbers. So once again, if you have a question over the phone, press *1. Thank you.
So our first question from Kelly, can you please go over the infection rate again and how that's calculated? So again, simply it's a ratio of the number of infections you have divided by the population at risk. That population at risk will change depending what infection you're looking at. Again, the examples I gave earlier, if you're looking at urinary catheter infections or UTIs, you're only going to be looking at those residents with an indwelling urinary catheter. If you're looking at something like respiratory illness or norovirus, you are going to be looking at the total number of resident days. And if you need the slides, didn't get them earlier, that link is also in the chat box. Another question that's come in, do you find it easier to have infection illness on the same spreadsheet as the antibiotic use or two separate sheets? I think really this is a personal preference thing. I mean, you certainly want some reference to that antibiotic use, whether it's a yes, no, or some marker on your general surveillance log, and then you may choose to have a secondary sheet where you put more details on. If you find it's easier to put that all together, it really just depends on your style and where you want to go to find that information, whether it's all on one sheet or on two sheets. And if anybody wants to chime in the chat box, I'd be really curious to know sort of what is the common theme out there. You know, so if you are doing surveillance and you find it much easier to do one way or the other, I'd be interested in those comments as well. Can you tell me where to find an specific infection control worksheet? There was one on the beginning of the slides as a link to one on our website. You can also check your Division of Public Health. I know that Wisconsin has one on their website as well. So a few comments coming into the chat box. Some people use separate sheets. One participant says they use the box on the main sheet and then that refers them to another sheet. Will a new line listing be provided with the recommended tracking data for infections? So again, if you go back to one of those first slides in this presentation, there is a link to a surveillance log sheet, and if that is not what you're looking for, just email me and I will certainly try and send something out for you to try. Is there a good reference to use to decide if an antibiotic was appropriate? $1 million question. So this is something you want to set ahead of time with your medical director. Again, there's a lot of literature out there. Your state Department of Public Health probably provides some of these things as well. Especially I know that in Wisconsin we're working a lot with urinary tract infections and what is appropriate antibiotic use for those. It is somewhat subjective to the type of residents you have and their particular circumstances, so what might be appropriate for one resident may not be for another, so it isn't as black and white as we would like it to be, unfortunately. But you want to have some of those things worked out with your medical director's involvement so that you can track them. Should the IP be auditing other departments, such as dietary, housekeeping, beauty shop, and therapy, or should the department head do this? I think ultimately the infection prevention is certainly responsible for sort of facility-wide, you know, as the big umbrella. But really, if you can work with those leads in those departments and have them be part of that surveillance, it will certainly make your workload easier. But it also, because they are involved, they would likely be much more involved in a solution to any problems that you're identifying. So I would say that that certainly is something that you should try and do, is get them involved in it as well. The certificate will appear after you do the evaluation. You will be able to print that and save it. So another question, a list for staff when to know when to contact the infection preventionist. So we talked earlier about what is your definition or what is your trigger point. We'll talk more about that when we do our outbreak call. But that should be part of your infection prevention plan or your policy, if you will. So when you have X, here the following people need to be notified. When you have Y, your local public health department needs to be notified. So you should have that material in a binder on your computer so that it is accessible, again, for off-shift people as well as the agency staff that wouldn't have the knowledge of your particulars in your building. One participant says that they have used the link for their infection and surveillance log, but kind of do additions to it, again, based on your risk assessment. There's also an antibiotic use tracking sheet under the tool options with the link that's given there. Can you print out the multimedia viewer notes when done? I guess I'm not sure exactly what that means. If you can give me a little bit more information there. If you are looking for the items that have been in chat, that will all be part of the FAQ that will be done later and will be posted on our website. Is there a way to get a printout of the slides prior to each of the future webinars? They will be posted prior to the webinars, but at this point they're in development. So I know that the slides for the next webinar, number 2, were just posted. The slides for webinar number 3 are currently just undergoing final evaluation. So I will try and get those posted as quickly as possible so that you can review them prior to the webinar and then get your questions in ahead of time. It's always helpful. I was not registered, but I participated in the conference. How do I get a certificate of participation? Wendy, I'm not quite sure because you weren't registered. If you want to contact your state lead, whether you're in Michigan, Minnesota, Wisconsin, we'll see if we can get you a certificate of participation. So the slides, as I was saying, will be posted on the event page as soon as they are available. Disposable items. Okay, I'm just trying to go over it here. I know another question, we didn't go over transmission-based precautions today, but the question has come up in my facility lately about whether to throw disposable items such as PPE from the isolation cart when isolation has been discontinued. Our policy has been to throw it out, but is it okay to have it located just inside the resident door? Then maybe it is okay to keep it. Again, one of those issues that don't really have a real black and white answer. You really have to look at it and think about what is the risk that those items have been contaminated. Ideally, we want to be able to not save things that potentially have been contaminated. But I will make sure and cover that a little bit more when we go over our transmission-based precaution webinar. So another participant states that they made surveillance sheets with areas for follow-up. What were the symptoms present? What interventions did we try before contacting a doctor? Do they meet the criteria for antibiotics? If they're started on antibiotics, then they have a separate sheet for tracking medication, route dose, etc., days of treatment.
Good risk assessment.
The evaluation had been placed, the link for the evaluation was placed into the chat box. We'll try and put that in there again. So where can you find a good risk assessment? Again, a good place to start is your state Department of Public Health. I do have one that I can send out as well that's very general, so just email me if you're not able to find one and we can get that to you. So they did put the link in again for the evaluation in the chat box. Are there any questions on the phone line?
No. Oh, wait, I'm sorry. There was a question from Caroline. Go ahead, Caroline. Is your line muted?
I have no question.
Okay, sorry about that.
Hopefully we answered it for you, Caroline. Thanks for trying. So another question in the chat box. We're seeing a lot of antibiotic starts for COPD exasperations, and the provider refused to order a chest x-ray. Do we have to be logging these antibiotic starts as HAI in our facility? Probably one of the best places to look for the definition there. If you work through NHSN, they have a definition for the respiratory infections and what would be considered HAIs. Again, if you want to email me, Nikki, I can get that to you. Another participant asked, infection tracking is done on a daily basis with antibiotic tracking as well as monitoring signs and symptoms. Then the master sheet is for risk of infection. So this is how they're doing it in their facility. Correlation of data is on the master sheet. So again, every facility has a little bit different way of doing it. I don't think one is really right or one is wrong. And Michelle Long, if you can just specify again which information you wanted sent. With all the questions popping into chat, I'm not just sure what your specific question was. Are there any other questions on the phone line?
No questions.
Thank you. Again, you can send me any questions by email that you think of after today's presentation. My email address is listed there on the slide. Our second call in the series will be in 2 weeks. We'll be talking about data. What do you do with this data? What all the surveillance data that you've been collecting, what do we do with it? That will be the topic for our next webinar. If you go on to the LFQIN, the Lake Superior Quality Innovation Network website, and look under events, the link should be there to sign up for the next webinars as well. Any other questions that you might have? Again, the link to the slides was posted in the chat box. We can throw that in one additional time. If you didn't see that earlier, if you just logged on, put that up again. The link for the evaluation is posted there again for you. So again, this is a little bit of a new format for us. Let us know how you like it. We tried to keep these to about a half hour. The education piece being about 20 minutes, 15 to 20 minutes, and then time for questions. Hopefully that has been helpful to you folks. I appreciate your listening in today and involved in the series. So another question. I have a patient with VRE and one with C. diff. They have both completed their antibiotics, no signs or symptoms, but the nurse practitioner wants to continue the contact precautions and isolation. What should I do? So typically, if they've had an active infection, their signs and symptoms are gone, their antibiotics have been completed, unless you are in an outbreak situation with C. diff, which is rare, I would say that there really isn't an indication to continue those contact precautions. I think really all that you can do is education for that nurse practitioner. Again, as you know, we try to make our transmission-based precautions as least restrictive as they can for the resident. This is their home. So they're asymptomatic, their antibiotics are done, there really is no reason to have them on isolation. Do you also track thrush or Candida, I'm sorry. I would say that not all facilities do. Certainly if you are seeing a lot of it, you should be. If your population is more at risk for it, again, that risk assessment that you're doing for your facility. So anytime you're seeing an increase in cases of something that you typically don't before, it should be a red flag for you. This is another case where your local health department would be a really helpful ally for your folks. Give them a call, tell them what you're seeing. But a lot of these will really, again, it really depends on that risk assessment that you're doing for your facility. So the infection control risk assessment is really a small piece of the facility risk assessment that you probably all did for phase 2 requirements and going into phase 3. So again, focusing just on the infection prevention portion to that. We'll give it just another minute or so if anybody has any additional questions. I have another one that just came in. If you have someone who's colonized with C. diff, still having loose stools, but has done so continuously in the 3 years we've had her at our facility. She is no longer on antibiotics. My question is, can we pull her precautions or not? So it is somewhat likely that your resident could become colonized with C. diff. That probably will not change for them their loose stools unless they have, say, a fecal transplant. So now, again, you're doing that individual resident risk assessment. Are they, continent of their stool, even though they're having loose stools? Are they compliant with their hand hygiene? They can wash their hands with soap and water before they leave their room and go out to general areas. Are they putting on clean clothes every day? What are their cognitive abilities? I mean, that's where you do kind of that individual resident assessment. What makes sense? Certainly if they've been on isolation for 3 years, that is a long time. And my guess is your staff probably isn't really following it. We really want those residents who need to be in transmission-based precautions or isolation on it and really get those residents out who don't. So in this case, she is still symptomatic. She's having the loose stools, but if they're contained, she's cognitive, her abilities are good, she can follow directions, I would have a discussion with your medical director, and hopefully you can get that resident out of isolation. When a resident is diagnosed with a urinary tract infection that isn't ESBL, what are your thoughts about reculturing the urine prior to discontinuing isolation? So again, it kind of comes back to that question of colonization. Certainly residents can become colonized with an ESBL or other organisms. I would really look at, again, that individual risk assessment for that resident. Are they symptomatic? Are they continent or incontinent? Certainly makes a difference. If it's a CRE, certainly you should be your health department, a little bit different than standard, ESBL. So again, when you have questions like that on a specific resident, this is where your local health department can be of help. You can certainly, ask them of your state lead as well. But you really need to do that resident risk assessment. So clarification on our C. difficile patient. She was not supposed to be retested for C. diff at the hospital, and now we cannot get a physician to agree to pull them. Our medical director is her physician. So that makes it a little bit more difficult for you. Here again is a place where, I've said this many times, but your local health department is your best resource for cases like this, especially where perhaps your medical director or another provider isn't in agreement with what you feel should be done by your protocols and policies. Talk to your health department. Sometimes providers will listen to them. An expert is always somebody outside of your facility instead of inside sometimes. Folks have some really good questions today, so I'm hoping that you found this helpful.
Excuse me, this is the operator. We do have a question on the phone.
Thank you. Go ahead.
Go ahead, Rob.
Okay. My question is, I have the McGreer's criteria that has community-acquired infection versus a long-term care onset or facility onset. McGreer's criteria is saying greater than 2 days. When you say 72 hours or 3 days.
Right. So in the beginning, you want to go by the McGear. So the first definition I gave when I talked about the fact that those definitions vary by the illness, it can vary by your state definition, your Department of Public Health. So that's kind of a general, if you don't have another definition, is that 72 hours. But McGear's for certain infections is very clear on their time frame. So that is what I would go by for McGear's.
Okay.
Thank you for asking for that clarification. What is a good resource to teach the aides how to serve safe foods? Off the top of my head, I do not have one, but I will certainly see what I can find you. I would think in some of the dietary guidelines, there may be something there. So if you want to pop me an email as well, Crystal, I will see what I can find, and then we will also include that in our FAQs. We'll also check on CDC. That's another really good reference that I had listed there, a good place to start searching as well. So I appreciate all your questions today. We went a little over our hoped for 30 minutes so we could get you folks back to your other duties, but I'm glad that you had a chance to ask and we had a chance to answer. Again, feel free to send in any other questions that you might have, especially in advance of the next webinar. If there are no further questions, do we have anything else on the phone line?
No questions on the phone.
Thank you, James. So again, in the chat box, you'll find a link to the evaluation once you answer that, and we really would like your input on that, again, especially because this is a little bit new format that we're using. You will then have a link for a certificate that you can print out and save. So we'll wrap up today's call and encourage you to register for the next call, which is in 2 weeks, and we will see you then. Thank you very much.
Thank you, ladies and gentlemen. This concludes today's conference. Thank you for participating. You may now disconnect.